you very much. I've shared the screen. I hope you can see it. Excellency, Chairman. I want to just move on to a different science, the science of public health, of health systems and policy. I'm going to talk a bit about the scale of the disruption of health and social care, some of it in terms of the impact, the impact, and then some of the mitigation measures. So I guess we all know that the really health and social service scaled down or curtailed across the board. Not only did it cover elective surgery and procedures were postponed, there was also prioritization of primary, secondary, rehabilitative, and long-term care. Access and uptake programs of childhood immunization were affected. Cancer screening programs were delayed. And more importantly, in developing countries, public health programs for HIV, tuberculosis, and malaria were adversely affected. And on the other side of the demand side, care-seeking behaviors of the population changed. People who needed care did not access services. And this is a study done in UK, where they look at people over the age of 50. This was, in fact, a population-based study. It's a longitudinal study of older people in the UK. And they surveyed 6,600 over people in random sample in the UK. And they found that in fact, 6% of all individuals had their operations cancelled. This is in total in the UK. And not only that, it affected, in fact, people who needed care. So you can see that in this PowerPoint, that people who had excellent health, a much lower proportion of people had their hospitalizations cancelled. But in people who had fair or good care, there was a much higher percentage, 21% of people who needed care had their hospitalizations cancelled. So it's not just people who were affected, but the people who needed care were adversely affected. And this is also the similar study that they did. When you look at access to general practice services, prescriptions, and community care in the over age 50 population in the UK, they found that about 1/3 of people during the pandemic needed to seek care from the GP. Of these individuals, about 2/3 were able to get GP access, but 1/3 did not. And of those who did not, the majority did try to seek care, but failed to get it. The other half did not seek care because they were afraid of COVID. However, in UK, prescription medicines were quite effectively dealt with because they made arrangements for people to get the prescriptions without having to see a doctor. And this is another study. It's a global study of the effect of COVID pandemic lockdowns on planned cancer surgery in 61 countries. So this is an international prospective cohort study. And what they found is that they've correlated the effects of lockdown. So the upper part is the lighter restrictions. At the bottom part when there's a full breakdown. So you can see that obviously there's a correlation between the number of lockdowns on surgical capacity. So when you have severe lockdowns, obviously surgical capacity is decreased. And the reasons that patients did not receive planned surgery, this is the same study. Very often it was due to the team to delay surgery. So the majority was due to the team delaying surgery. They also changed some alternative methods. But patient choice to avoid surgery accounted for 23%. So although they were still available, but patients did not want to have surgery. So there were a whole list of things that contributed to people unable to travel to hospitals. There were patients delayed due to infections. Some patients died of COVID while waiting for surgery. So a lot of these disruptions and the multiple causes for it. Of course, there were some non-COVID related. And this was a study done in UK. Of the detection. So this is the screening programs for colorectal cancer in UK. Of course, during the pandemic in April, there was a drastic reduction in the number of colonoscopies. Of course, because of that, there were also quite similar reduction in the individuals referred for subsequent confirmation of in treatment for suspected cancer. So there's a correlation. It went up, but still that's going to be a big factor. So another study is a global study, a global collaborative study on pandemic care on cancer. And this was a global study of 356 centers treating cancer from 54 countries. And you find that, of course, as you'd expect, a very small percentage continue to be fully operational. Most of the centers had reduced workloads. Some were partially closed. And then the reasons for interrupted care was usually precautionary measures. The system became overwhelmed, shortage of staff, and lack of PPE. So there's a whole range of things that affected the cancer care throughout the world. Right? And on the other element, so the important thing is that a lot of in our literature, we neglect community and social care. Of course, these are all related to health needs of the vulnerable populations. And this was the same population that was studied. This was the cohort, the longitudinal cohort of older people in England. And you find that, in fact, of all the individuals, so this is a representative population of the whole of England, only 42% said they did not need access to community and social care in UK. 10% of the population needed and received care. 70% needed, sought, but did not receive the care that they needed. And 14% needed care, but did not seek care. In Hong Kong, this is the data from our government. Much of the social care was closed. So our community health centers, our social and rehabilitation centers for disabled, integrated children and youth services, community centers, they were all closed. There were certain centers that were open, suspended, only for those in special need. So daycare centers for older people, integrated vocational rehabilitation, day activity settings. But even the ones that had the normal service but limited, our respiratory care services, even home service for people with disability. So much of this really was not available to many people who required it. So these were people that had disabilities and needed support services in the community. And even our visiting medical practitioners, the residential care homes, were curtailed to an extent. So I just want to talk about some of the mitigation measures to end up. This is a guidelines from WHO on operational strategies for maintaining essential health services. So we need to look at the governance and coordination mechanisms to support timely action. We need to prioritize essential health service, how to optimize service delivery settings and platforms. We need to establish safe and effective patient flow, optimize health worker capacity, maintain availability of medicines and equipment, fund public health and remove financial barriers to access, strengthen communication strategies to support appropriate use of essential services, monitoring, and then use of digital platforms to support essential health service delivery. Of course, the problem is that there's been a big impact of disruption, right? The failure to access needed care impacts on mortality and morbidity from preventable and treatable diseases. Backlog of the resident needs will take time to resolve and need to be addressed. And of course, there are also new demands from depressive and anxiety disorders and from long COVID. In conclusion, in the pandemic, there have been innovations on health and social care models can be provided, including the widespread use of telehealth. These are options for technologies from the disruptive demand to be institutionalized in our systems. And then more importantly, examination of health system resilience, how health systems respond, adapt, absorb, and learn from the disruptive public health crisis will be critical in preparing for future threats and maintain access to needed care. Thank you.